This video lecture will accompany our chapter on the microsurgical management of giant intracranial aneurysms. Giant aneurysms are defined as having a size greater than or equal to 25 millimeters in diameter. They originate from a defect in the media of the arterial wall or, in rare cases, from trauma. You can see from the illustrations that the majority of these start as saccular aneurysms that progressively enlarge, but there is a subset of dolichoectatic aneurysms that also arise either from dissection or from some degenerative process in the arterial wall. These giant aneurysms enlarge over time and begin to exert mass effect and neurologic symptoms from compression of cranial nerves or adjacent brain tissue. They can also rupture as their size increases and the walls thin. The treatment of giant intracranial aneurysms is, in my view, largely a surgical disease, given that endovascular therapy has been plagued with high recurrence rates. Therefore, the treatment decisions center around the surgical approaches and the exposure of the aneurysm. This list is a shortened one, but gives you the workhorse approaches that are used to expose and treat giant intracranial aneurysms. The illustration on the left demonstrates the exposure of the orbitozygomatic pterional craniotomy. This essentially goes down to the circle of Willis and is ideally suited for middle cerebral artery aneurysms, supraclinoid carotid aneurysms, ophthalmic artery aneurysms, giant PCOMs, and in addition is used for anterocommunicating artery aneurysms. The illustration also demonstrates the transpetrosal exposure through the petrous bone and the far lateral exposure. The illustration on the right shows zones of exposure of the basilar trunk and in particular the posterior circulation, showing how the extended orbitozygomatic is suited for lesions at the basilar quadrifurcation. The far lateral approach is ideal for aneurysms of pica and the vertebral artery. The transpetrosal approach is used for basilar trunk aneurysms. This table is meant to give you a flavor for the distribution of giant aneurysms. You can see from the table that many of these aneurysms are located on the internal carotid artery, anywhere from a third to two-thirds of these aneurysms. The middle cerebral artery is also a common location. Decreasingly common are giant aneurysms in the anterocerebral artery circulation and in the vertebrobasilar circulation. The diagram on the right demonstrates these frequencies graphically. The surgical approach is selected based upon the location of the giant aneurysm. The orbitozygomatic and pterional approach is ideally suited for giant aneurysms of the internal carotid artery, the anterocommunicating artery, the middle cerebral artery, and the basilar bifurcation, which includes the basilar apex and the superior cerebellar artery. The interhemispheric approach is chosen for the distal anterocerebral artery giant aneurysms. The far lateral exposure is chosen for pica, vertebral artery, and some vertebrobasilar junction aneurysms. Petrosal approaches or an extended retrosigmoid approach is selected for ICA and mid-basilar trunk aneurysms. Some giant aneurysms are amenable to clipping with the basic clipping techniques that we use for regular non-giant aneurysms. This illustration shows some of the more basic techniques with simple clipping, intersecting clips, and stacks of clips. The bottom right illustration also shows the use of fenestrated clips to overlap. However, these clipping techniques are often inadequate if the neck is too broad or the aneurysm too large. These are some additional techniques. The tandem clipping technique is a nice one. It allows a straight fenestrated clip to close the distal portion of the neck, and then additional clips on the proximal neck then close the fenestration of the initial clip around a branch trunk that goes through the fenestration or around perforating arteries that also go through that fenestration. The bottom illustration shows the use of additional fenestrated clips as booster clips. Tandem angled fenestrated clips are ideally suited for proximal internal carotid artery aneurysms. The tandem clip is basically a stack of these typically right angle or could be 45-degree angle fenestrated clips that begin at the proximal neck and work their way back to the more distal neck with parts of the clip blade overlapping heel to toe so that it forms an occlusive barrier. Other tandem angled fenestrated clipping techniques include the counter clipping techniques that are facing, meaning that the clips are placed toe to toe, or counter clipping crosswise with the clips placed in opposite directions, heel to heel. Fenestration tubes are another construct that are very useful for using the fenestrated clips to fenestrate one of the branch vessels. The antegrade tube creates a tube of the fenestrated clips that transmits an artery flowing in the antegrade direction. A retrograde tube uses the tube to reconstruct the origin of the branch artery, but then has a closing clip as the last clip to occlude that tube or that tunnel. The dome tube is basically a picket fence application of clips that uses the tips of a stack of clips or a row of clips to reconstruct the neck at its point of closure. Another useful technique is to clip reconstruct, meaning opening up an aneurysm, removing thrombus, taking out a portion of the fundus or the aneurysm dome, and then using that reduced aneurysm tissue to then close once again. It can be closed with this picket fence, a stack of clips, or in any kind of variety of clipping techniques that basically refashions the neck. In my personal surgical series, nearly a half of my giant aneurysms were treated with bypass and trapping, which speaks to the fact that many of these giant lesions transform themselves into something that can no longer be successfully clipped with the traditional techniques. Therefore, this bypass and trapping is an alternative strategy. It allows you to revascularize the outflow arteries as a first step, and then, once that revascularization has been completed, the aneurysm is simply isolated or excluded by trapping clips. This allows a more staged approach. It's all done in the same operation typically, but by first doing the revascularization, it then gives you tremendous flexibility and an upper hand to close down the aneurysm and either go inside and remove clot or coils and get the aneurysm closed down. This table demonstrates what I refer to as the 7 different types of bypasses. The 7 different types of bypasses refer to the ECIC bypasses that use scalp arteries, the ECIC bypasses that use interposition grafts, typically from the cervical carotid artery. The next grouping are the intracranial to intracranial bypasses that use reimplantations, reanastomoses, in situ bypass techniques, or a short jump graft to create the bypass reconstruction. The 7th type is basically a combination bypasses that uses any of these other 6 types in a combined manner to revascularize multiple outflow arteries from the aneurysm. This next table shows the application of the 7 bypasses, and the point of this is to show that even though the majority of bypasses still are first and second generation or ECIC bypasses, there are many of these bypasses that use these intracranial to intracranial techniques, and these allow the bypass techniques to evolve and become more refined. The 7 bypass framework allows you to entertain a variety of different bypass options and to choose a bypass that is easy to do or most beneficial for the particular pathology. This is an animation that just demonstrates a use of bypass to treat this very difficult aneurysm. So what we're going to do is to first put in an interposition graft. This is an intracranial to intracranial jump graft that uses the A1 segment as a donor and revascularizes the M2. The ends of the M2 are then transected from the aneurysm and reimplanted to one another in end-to-end fashion so that the jump graft can then revascularize both its recipient artery and the other trunks on the MCA territory through this middle communicating artery. The aneurysm itself can then be trapped either with distal clip occlusion as shown here or with complete trapping if the lenticulostriates allow this. This case will demonstrate an STA-MCA bypass with thrombectomy and clip reconstruction of a giant middle cerebral artery aneurysm. The patient is a 62-year-old man with hypertension, hyperlipidemia, and hypothyroidism. He presented with transient slurred speech and mild left-sided weakness. Imaging demonstrated a giant thrombosed right middle cerebral artery aneurysm with occlusion of the temporal trunk and multifocal right-sided infarcts. The patient was admitted to our hospital after being transferred from another one and started on a heparin drip. Here is his MRI demonstrating areas of infarct in the basal ganglia and caudate nucleus. The MRI and CT angiogram demonstrated this giant right middle cerebral artery aneurysm. The angiography is interesting in that the aneurysm is seen, but also if you notice, the frontal division comes out of the base of the aneurysm and fills out very nicely, but if you look for a temporal trunk coming out on the inferior side of the aneurysm, it has already been occluded by the thrombosis of the aneurysm. The patient was taken to the operating room and placed in the supine position as demonstrated here in this illustration. The incision and craniotomy is demonstrated with the modified orbitopterional craniotomy being used here. Here's the view down to the sylvian fissure, and the dissection is now behind the aneurysm looking for this frontal division of the middle cerebral artery bifurcation. These are some arteries on the temporal side. These are widely patent and are the anterotemporal arteries passing by. Here you can see the full size of this giant aneurysm in the sylvian fissure, and you can also see this adherent anterotemporal artery. Back on the frontal side, you can see the frontal division here bifurcating just beyond the aneurysm, and you can see as I dissect down along the wall of the aneurysm how adherent the trunk is to the aneurysm wall. So this is our recipient site for the bypass. This is the STA to MCA anastomosis being performed. You can see the running continuous technique. Sutures are being tightened. After the bypass is complete, you can see a patent STA-MCA bypass here with some backfilling of the aneurysm. Now attention is turned to the clip reconstruction. You can see here one of the anterotemporal vessels adherent to the sidewall, and you can also see now as I try to dissect down how adherent that frontal trunk is. So as I place this temporary clip on the M1 segment, the aneurysm softens dramatically, and I can move it more aggressively with my suction to free it from the wall of the aneurysm. So now I'm dissecting down right to the junction of this frontal trunk and the M1 segment feeding the aneurysm. You can see how that trunk has been freed completely, and now I'm working my way behind the aneurysm. This first clip is just a tentative clip to close the aneurysm neck, and with that clip I'm now able to enter the aneurysm, evacuate some of the blood within it, and then work on the thrombus. So first the thrombectomy is performed with this pituitary rongeur, and later I'll use a CUSA. Now that the aneurysm has been debulked, I'm able to get behind it a little bit more aggressively, and what I'm looking for here is the temporal division. I've just applied another clip to close the neck. Here comes the CUSA, and you can see more organized thrombus within the sac of the aneurysm. So I'm creating a stack of fenestrated clips to get across the neck here, and that's nicely closing off the sac of the aneurysm. With each stacked fenestrated clip, I'm advancing it higher up the neck. But you can see as I come off with this first or early fenestrated clip, there's still a connection or bleeding through the neck, which is coming from that distalmost portion of the aneurysm. So it's going to take a little bit more dissection to get all the way across that neck. So the clip goes back on, and I've learned from that maneuver that the tips of the blades aren't fully across, and I'm having to remove some of these clips and make some readjustments that will advance one of these deep fenestrated clips deeper. So here you can see I'm advancing that clip deeper across the neck. That will get me all the way across the aneurysm neck on the deep side. And now I believe I've closed off the aneurysm neck effectively. So I'm reconstructing the curve between the M1 segment and the frontal division. Now the temporary clip can come off, and we've reconstructed that flow from M1 to M2. You can see the anterior-temporal artery there, nicely preserved. On the back side, you can see the temporal division, but this is already occluded. Here's the icy green showing good flow in that frontal division coming around from the M1 to the M2. You can also notice a patent bypass as well. His postoperative angiogram also showed some interesting findings. Despite what appeared to be at surgery a good clip reconstruction from M1 to M2 on that frontal side, you can see how that trunk no longer fills from the M1 segment. But if you look to the right, the external injection shows good filling of this temporal artery bypass with filling of the MCA and all three major trunks coming from that frontal division. So his main supply to that hemisphere was nicely preserved by the bypass. This is a table of surgical outcomes just to make the point that there are a number of large surgical series done by expert surgeons, and if you look at the complete occlusion rates of these surgical techniques, they ranged from the mid-80s to the 100% range. So the occlusiveness of surgical therapy is quite high, and if you look to the columns on the right, the rates of excellent or good outcome are also quite high in the generally mid-80 or so range. These aneurysms are extremely challenging and quite difficult technically, so that poor outcomes and deaths are observed in these series, but the overall good outcome rates speak to the efficacy and the preferability of microsurgical therapy. This next table highlights some of the more recent endovascular series, and it's meant to just make the point that if you consider the previous table and you then consider these endovascular results, the rates of complete occlusion are significantly lower, and this has to do with the inefficiencies of endovascular coils for giant aneurysms and also the difficulty of endovascular therapy for thrombotic aneurysms. You see occlusion rates that range from the high teens to the 50 to 60% range. You see excellent and good outcomes that are maybe a little bit less than what we see in the open surgical series. And here, too, you see a significant number of poor outcomes and death. In conclusion, giant aneurysms produce neurologic compromise through their mass effect on cranial nerves or on brain tissue, or with aneurysm rupture. The treatment of these giant aneurysms requires the application of our basic fundamentals in aneurysm surgery, which include complete vascular control, temporary clipping, and complex techniques to reconstruct the aneurysm neck. With thrombotic aneurysms, these often present with ischemic symptoms, existing infarcts, and branch occlusions, and these represent a step up in the technical challenge. To deal with thrombotic aneurysms, they often require thrombectomy to soften the neck and convert it into something that is clippable. For those giant aneurysms that prove to be unclippable, bypass and trapping is the preferred strategy. Bypass provides protection against ischemia during the temporary occlusion time, but more importantly, it revascularizes the outflow vessels, the efferent arteries that enable the aneurysm itself to be trapped or occluded proximally and distally. Bypass procedures represent a very important contingency strategy, or more accurately, an alternative or primary therapy for many of these giant aneurysms. Thank you.